Good afternoon, and thanks so much for joining the conversation today as we talk about how care and outcomes can be improved for patients who come to the emergency department in the midst of a mental health crisis. Before we begin, I would encourage you to leave questions in the comments section. We'll do our best to incorporate them into today's conversation. I'm Heather Livingston, Chief Operating Officer of the Facility Guidelines Institute and Managing Editor of the Guidelines for Design and Construction Documents. If you're unfamiliar with the guidelines, these documents are minimum standards for planning, designing, and constructing hospitals, outpatient facilities, and residential care facilities. I'm pleased to be moderating this important discussion today. Joining me are our panelists, Virginia Pankey, Principal and Senior Medical Planner at HOK, with a focus on behavioral health, and Dr. Scott Zeller, a leading emergency psychiatrist and vice president at Vituity, a physician-owned and led partnership that's dedicated to transforming healthcare and improving the lives of patients. Both Virginia and Scott are members of FGI's 2026 Health Guidelines Revision Committee. That's the body of volunteers who are responsible for updating the guidelines documents. Thanks so much for joining us today, Virginia and Scott.
Thank you so much for having us.
Yeah. Good afternoon from the Midwest.
Okay, so let me set the stage here. Over the last 15 years, the percentage of patients who arrive in emergency departments due to behavioral health illnesses, issues such as mental illness or substance abuse has doubled, expanding from about 7% in 2007 to around 14% today. This increase has strained a system that's already under pressure, and it's exacerbated staffing challenges, which results in higher costs of care as well as poorer health outcomes. Recognition of the critical need for behavioral health care settings that are able to deliver the right care in the right place and at the right time led FGI's 2022 Health Guidelines Revision Committee to focus on creating spaces where individuals who are experiencing mental health crises can receive care safely and effectively. In order to accomplish this task, FGI convened a topic group that was led by Virginia with support from Scott and other behavioral health care experts to develop minimum design requirements for behavioral health crisis units. These units offer a distinct space located close to the emergency department with controlled access in and out. And this is where emergency stabilization care can be given to behavioral health patients in a calming and a safe environment. The recently released 2022 edition of the guidelines has provided new minimum standards for these units, and an expansive white paper published earlier this year provides supplemental information and best practices for creating healing spaces that go beyond the minimum requirements. This white paper, Design of Behavioral Health Crisis Units, is available without charge on FGI's website. So with that background, let's go ahead and begin. Briefly, can the two of you describe what factors are contributing to the mounting healthcare crisis that we're seeing in the United States?
You want to go ahead on that, Virginia, and then I'll pepper you with one of my thoughts.
Sure, I'll do that. So there historically, it's really been decades in the making. There just aren't enough facilities in the United States for people with behavioral and mental health care issues. And that's along the entire continuum of care. So a lot of time, mental health patients, the only way they enter the healthcare system is through the emergency department. Sometimes some things happen in public, and they come through the justice system because they've done something that's unsafe to themselves or to others, and then come into the healthcare system. While somebody who breaks a leg and has a bone sticking out knows they need to go to the doctor right away and get treatment, it takes a mental health patient much longer to seek care. And then when they do, it's often when they're in extreme crisis.
Yeah, that's absolutely true. And, why has this increased so much in the last 10 to 20 years? That's one of the great puzzling questions that faces those of us who work in emergency settings. But the reality is that it's happening, and we need to look at good ways to address it. One of the most stunning pieces of data that are out there is that over the last decade, the number of people coming to emergency departments for reasons of suicidality, after a suicide attempt, suicidal ideation, self-injury, things of those nature, has gone up over 400%. I mean, that's a stunning figure. Imagine if any other medical condition had gone up over 400% in 10 years. I think there'd be very little else we'd be talking about. But unfortunately, suicide is kind of something that doesn't get talked about a whole lot in the public spectrum, because it's got a sense of stigma, shame, if you will, around it. So we probably don't discuss it enough. But that's not the only psychiatric emergency. There's delusions, hallucinations, paranoia, dangerousness to self or others, and as was mentioned earlier, different kind of substance intoxication, withdrawal, delirium, things like that. The real fact is we're just seeing a lot of it, and it's really incumbent on the places that are seeing these patients to develop good methods and metrics and plans on how they're going to treat with them. Because if the number of patients having heart attacks went up 400%, you can guarantee that all the hospitals would be gearing up for that. So we should be doing the same thing for mental health emergencies, which actually federal laws identify as being a true medical emergency.
Thanks. Those numbers really are quite shocking. Obviously, we're talking about emergent patients who have a crisis that needs to be treated in the ED. What are the historic problems with keeping these patients in the ED when they come and visit? Can you elaborate on that a little bit?
So I'll take that first, if that's okay, Scott. So
Sure.
when you go to the emergency department, which most of us have, either for our own situation or family member situations, um, you're in a crisis. There's something really wrong with you or your family member. You're coming here probably for the first time, so that can be a little overwhelming. And then it just seems like an extremely chaotic place to be. And if you're already in a mental health crisis, and you're surrounded by this chaos, it's not really a very therapeutic place to be. The other thing is it's a hospital, so it's very institutional looking, not warm. That's kind of scary. Um, if they don't have space to accommodate you, and they don't know what to do with you, they think they're going to make you an inpatient right away. Often when you're having a mental health problem, you're not really being treated, and maybe they don't have a room for you, or they lock things down, so it seems like a very sterile place, and they shut you in a room alone, and you feel like you're in a cell even though you're in a room in a hospital. So it's just not very conducive or calming for the patient.
Yeah, those are excellent points that you make, Virginia, and it really, from experience I've had talking with patients, there really often is a feeling of confinement or being punished or trapped in a cell, as you described. A lot of our patients are feeling very despondent or suicidal, or feeling like they don't want to live any longer, or conversely, they might be extremely paranoid or delusional and thinking that people are plotting against them and trying to hurt them. In either one of those situations, being kind of confined to a small room with a sitter or security guard or a locked door can feel like a punishment, or the opposite of a therapeutic environment. And so that's been a shortcoming of the emergency rooms, which is really not the fault of the emergency departments, because they really weren't designed to be places for behavioral health healing. They're there to help you, like we were describing before, if you have a broken leg, or if you have chest pain or trauma, or something along those lines. And so what works very well for those types of medical emergencies may not be the same type of environment that is supportive for somebody in a mental health crisis, who might feel much better if they were not feeling claustrophobic, if they had room to move about, if they felt safe and more like in a comfortable space. We might see different outcomes. And one of the things that also that Virginia mentioned, which is often emergency departments, because they have not been set up for mental health crisis patients. Their often default treatment is, let's find this person in an inpatient psychiatric hospital to transfer them to. And often when they see somebody in that unfortunate environment, the patient looks so acutely ill that it seems like inpatient might be the most appropriate destination. But what we've seen from our work with behavioral health crisis units is that if we get somebody into a different environment, actually the great majority of those patients can actually get better and be able to go home in less than 24 hours if we do things a little differently. And that was part of the basis of the whole FGI, BHCU, behavioral health crisis units work.
Yeah, that's really remarkable. Quite a stark difference between sending somebody to an inpatient behavioral health hospital or sending them home in 24 hours. So, as both of you know, the 2022 edition of FGI's guidelines do present the behavioral health crisis unit as an option for treating patients with these mental health emergencies. Can you describe what are the key components of a behavioral health crisis? What sets it apart and makes it that calming space?
I'll say the most important piece is the multi-patient observation room, often referred to as the milieu um, in mental health facilities. So this is a space that is open, that has recliners in it. It has no walls around those individual recliners. It allows for visibility between the patients themselves and for the caregivers to have easy access to them. There'd be a care station adjacent to that open area, but the caregivers um, don't just sit behind that care station. It's highly encouraged that care station is open for visibility and acoustics, and it allows the patients to walk around and pace if they need to, if that's something that can calm them. Um, there are lockers for the patient's belongings. The patients knowing that their things are close by is comforting. And there's a quiet room proposed for immediately off of that multi-patient room. So if a patient realizes I'm becoming agitated, I need to be in a low stimulation environment, I can step into that room and be by myself. Scott, would you like to talk about the importance of that?
Yeah, I think one of the things that we discussed a lot in the FGI Behavioral Health Crisis Unit committees was about that open space and that ability to really have direct visibility, a gentle line of sight observation by the staff with all the individuals there. One of the big things with design of behavioral health patients in emergency settings over the last few years from national surveying agencies has been making rooms ligature safe. And most of that, and what I mean by ligature safe for those unfamiliar, is having no places where somebody could create an ability to hang themselves or tie down something where they could asphyxiate themselves. That's mostly been because the patients were placed in areas where they weren't under direct line of sight. But if you change that whole formula and have a situation where everyone's in a big room together and the staff are actually intermingled with them as opposed to being behind a nursing station somewhere and not really interacting with folks, you create this kind of direct observation. And as I mentioned before, but it's gentle. It doesn't look like somebody's staring at you. They're just kind of in the same room with you. And people sometimes will say, "Boy, if I was coming to a hospital with a crisis, I don't know if that I'd want to be in this big room with a bunch of folks together. I'd rather be in a private space." And that might make sense to us, but that means that you probably have never been through a behavioral health emergency if you think that that's the situation you want to be in. Real quick example. Let's say that you are severely suicidal. You don't want to take another breath on earth. You think everybody in the world hates you. If you went to a place and they put you in a private room and closed the door, you lie in the mattress, you look at a bare ceiling, what's changed? Nothing. The world's still a horrible place and maybe everybody hates you. But if you go into a room where there's a communal area and you're able to walk around freely, you're not being confined, you maybe can sit up and get yourself something to eat or drink. You can sit at a table and maybe join in a game of dominoes or cards or and maybe make a new friend. Maybe it's another patient, maybe it's a staff member, maybe it's a peer support specialist. But once you start interacting and making that friend, maybe the world's not such a bad place anymore, and you have a little bit more hope. And maybe that suicidality starts to diminish. And that's something that we find is really important. That first 24 hours of a behavioral health crisis, human interaction is paramount and really trumps any idea of, I want to be alone and by myself. That's actually, you want to be with other people. It's very reassuring. You feel a sense of safety, and you can see that you're not going through this alone.
Thanks. That's really important to note. How could behavioral health crisis units be applied to outpatient settings?
So, one thing to understand it real quick is that, I'm sorry, Virginia, I think I spoke over you. I was just going to say that, the behavioral health crisis units in hospitals are technically outpatient. They're usually either part of the emergency department, which is by definition outpatient, or they're called outpatient observation areas. So these are outpatient, but I'm believing that your question is more along the lines of, could this be done outside of a hospital setting in an outpatient environment? And there are a number of community-based crisis facilities that are out there, and they're wonderful, wonderful programs, and they do have a lot of success. The issue tends to be between these and the ones that we see in hospitals is that the community programs are more set up for people who are there voluntarily only, who are having more mild to moderate crises and don't have any medical comorbidity. And so that limits the amounts of patients they can see. And the people who are excluded from that would be those who are on involuntary status, those who have very high acuity symptoms, those who are considered dangerous to self or others, who have any kind of substance intoxication or withdrawal, and any other kind of medical comorbidity, including being right after taking an overdose or self-injury. So there's a distinct difference in the level of where these kind of facilities fall on the spectrum. And we really feel like the hospital-based or behavioral health crisis units or outpatient ones that are adjacent to some kind of medical urgent care or standalone emergency setting where we can guarantee that we have medical care close by should that become necessary, is going to open up the door to a much broader range of patients. That being said, we want to have those outpatient community facilities, and we would love as many patients as possible go there and go voluntarily. The reality is that there's a certain section of patients who are going to be too acute or are going to have those medical issues, and that's going to mean they're going to end up going to hospital emergency departments. And the BHCUs are in those facilities are really set up as a way to get those folks in the right place at the right time with the right personnel, without having to have them seen there and then transferred outside of the facility.
And I'll say, looking at this from a very architectural standpoint, there, as you're working through the planning, there are certain elements that are called out in the behavioral health crisis unit guidelines that you can share, like soiled utility rooms, clean supply, so that if you are immediately adjacent to an emergency department, there's an efficiency in space by having that. I believe that there's probably going to be a high number of these units that are built at existing hospitals, and they may not have room immediately adjacent to the emergency department, but maybe they have something further down the hall or a different part of the hospital. I'm working with a client that has a psychiatric facility adjacent to the main hospital campus. So they're going to have their behavioral health crisis unit within that department. So sometimes I will say the guidelines allow for those different circumstances. Just some of the things can no longer be shared. And I think that's really, we try to be realistic in how this may come together, and the guidelines are helpful in that.
Okay, that is actually about all the time that we have. If there are questions that we were not able to get to, we will be sure to follow up with you after the event. This discussion is also, sorry, what was that? All right, this discussion is also going to be viewable on HOK's LinkedIn page long after today, so we hope that you will share this conversation with your friends, with your followers. Scott, Virginia, thank you so much for being here today and talking about this, and thanks to everybody who logged on to join us. Bye.
Thank you.
Thanks so much.